Well, hello, everybody. Welcome to our webinar this week. My name is Dara Wheeler. I'm Axiom's Chief Marketing Officer, and I'm really excited to have an amazing panel to join us today. We have got a great topic. It's called New Day, New Ways for Managing Employee Health in 2022. And although we've been thinking and talking a lot about the coronavirus and the impact to employers, I think switching gears a little bit and thinking more broadly about employee health and how we can affect employee health differently. We've got a really great panel of experts that I'm going to have introduce themselves in just a moment. In the meantime, I wanted to point out a couple of things from a housekeeping standpoint. We have got some resources at the bottom of your screen that are available for download, and you're welcome to do that at any time. And in addition, we will be recording this and sending the recording out to the email and as well on our social media platforms. If you have any questions, please submit them. There's a Q&A box, and we've got an amazing group helping us on the Q&A team, and we will address your questions during the session. In addition, if you have any technical issues, please reach out to that same team and they will help you. Okay, let's get started with our speaker panel. Dr. Cherry, would you like to start, please?
Sure. Well, good afternoon, everyone. Thank you for tuning in. My name is Scott Cherry. I'm Axiom Medical's Chief Medical Officer. My professional background is I'm board certified in preventive medicine, public health, and occupational environmental medicine. And really those specialties focus on population health in the general public and as well as in employee health. And I've been supporting the military, government, and industrial operations for the past 15 years. And I will hand it over to Dr. Dickerson.
Hi, I'm Cristin Dickerson. I am a practicing board-certified radiologist and spent most of my career here in Houston with multi-specialty groups. I was actually president of Diagnostic Clinic of Houston and then went on to staff Medical Clinic of Houston, or Sunset Clinic. But about 10 years ago, I saw a need in the community to start something new. And so we started a medical imaging network. And that's the newest part of my story.
Wonderful. Thank you both. And a lot of people may be thinking, how does this relate to all of the things that we've been talking about employers, and how does diagnostics and imaging relate? And we'll definitely get there. So we've got a few discussion topics. And as we think about employee health in the workplace and how to best address it, those of you that have helped us or participated a lot in these webinars, Dr. Cherry and I speak a lot about total worker health and how best to help employees in the workplace. So we'll dig into a lot of those topics that are familiar to our audience, but in some different ways. So I'm really excited about that. So the discussion topics today, we're going to talk about the old days, old ways of working, and how this eye on employee experience is becoming more and more important. Dr. Dickerson and I were both talking before the webinar about the labor market and challenges around staffing and making sure that we have good people staffed, and that's going to continue to be an interesting challenge over the next couple of years. And then driving change with diagnostics and imaging and what that looks like. So Dr. Cherry, can you talk to us a little bit about the old ways of managing workplace health and safety?
Mm-hmm. Sure. And, I think I can probably frame it up for about the past 30 years, although I've been actively in the field for 20, I did get a really good sense of the previous decade or so as well. And, large corporations with internal medical departments, probably even including the government with my direct experience was with the U.S. Army supporting the civilian workforce in special populations, as well as soldiers that worked in those populations. But probably beyond 20 years ago, in employee health, a lot of employees saw the company doc or clinic as their doc. And, men probably are worse than women about seeing their own doc. But if they had to come into the employee health clinic for a specific work-related exam or test, they kind of got a full kind of Cadillac full service exam and lots of attention with regard to personal health as well as employee health, whether it's OSHA required medical surveillance exams, but really addressing the total health of the employee. And there was really a huge paradigm shift in the last 30 years to where, corporate financial responsibility started looking at the spend on the employee health side and then on the personal health side. And they said, let's really validate what we're offering from a kind of a needs-only perspective with regard to employee health based on just their workplace hazards or requirements. And so there started to becoming siloing of employee health back into what I consider now is the traditional model of you have employee health that the company pays for, but doesn't really address the holistic health of the employee. And then you have personal health insurance that's supposed to deal with that. And, there's a host of reasons why this siloing effect has really, in my opinion, degraded the overall total worker health of the employee population on average. And, especially the clients that we support, a lot of them have safety sensitive work. And so what that means is if they do not do their job appropriately, they can injure themselves, their coworkers, the community, or the environment. And so personal health bleeds over into employee health, where it's not really regulated. So, for instance, if someone has uncontrolled medical condition that may make them lose capacity of their cognition or of their physical abilities, that could drastically affect the health and safety, again, for that person, the company, and the community. And so, again, there was a tremendous blurred lines of personal and employee health decades ago, and now it's quite siloed. And we're hoping, as Dara and I have thought through this, corporate wellness was kind of that bridging of the gap between those who don't really engage in the personal health insurance market, or maybe they're underinsured or not insured. I know Dr. Dickerson can speak to that later as well, but politically, I know there's the discussion about the uninsured, but I've been managing population health for well-insured, quote unquote, people for very large companies, and their health usually is very similar to the communities that they work in that may not actually have health insurance. And so there's obviously an issue with potential quality, effectiveness, all along those lines. And so what ultimately happens is the employer ends up with the responsibility and the liability if they're getting injuries that they have to report to OSHA. There's lots of implications. At minimum, their workers' comp insurance rate goes up. And for certain industries that we specifically support, it actually negatively affects their ability to bid for work in certain kind of industries. And I'll leave it at that. And so I think also what's happened in the last 30 years, some for good reason and some have unintended consequences, is that due to privacy and HIPAA laws, the ability for employers to effectively manage their employee health and fitness for duty has become more and more challenging. And so we kind of see this perfect storm of where we're at now with personal and population health kind of degrading to levels that we've never seen before. We're starting to see life expectancy starting to instead of increase as usual, it's static or potentially declining. And the last thing I'll say is, COVID has shown that there are vulnerable populations with comorbidities that could be addressed by better engagement into the healthcare system more effectively. And so I am optimistic that there is maybe a silver lining to a degree that not only do individuals take their health more seriously, but companies, health insurance program documents and policies and plans can allow for more flexible engagement into more effective utilization of the healthcare system.
Great points, Dr. Cherry. Before we jump into more of the historical context, anything, Dr. Dickerson, you want to add to that?
Yeah, I think that the increasing cost of healthcare, challenged employers, and more of the cost was as he referred to, passed along to the employees, such that many of them, are paying 20% of their income for a high deductible healthcare plan, meaning, there's this $4,000 deductible. They don't have anything left to pay for healthcare. And so, that's been one of the challenges. And, the other is we still have a large, problem with silos in healthcare, and I agree with him that HIPAA, has been problematic, and there's some good things emerging, as a result of the pandemic, that are going to change that. But healthcare in silos has been problematic. I mean, we know that 40% of follow-up exams never happen in imaging because it was ordered by a doctor that doesn't deal with that kind of problem. So, if it was a MRI of the spine and there was a liver lesion, that doctor doesn't deal with liver lesions, and nobody ever notices and gets that patient off to get the appropriate follow-up. So, that's healthcare in silos. And, I think that's something that has to change.
Dr. Dickerson, you kind of maybe gave me an epiphany here, because I was thinking what really caused this shift from employee health clinics, whether it's on-site or off-site, shifting from kind of really dealing with the whole health of the employee to now having these silos. But that's probably one of the biggest causes of that was as health insurance costs rose. I know the companies were then looking at ways to save money. So if they're beholden to provide health insurance, and as that insurance became more and more expensive, they probably cost shifted what was part of the internal medical departments. With their mission was really employee health, but again, it was heavily utilized for whole health. And so that may have been kind of a way to slowly help some of that pain, but I'm not sure if there really was effective in preventing that. But I think your comments have really opened my eyes to maybe what was causing that back then.
Yeah, great points. Dr. Cherry, the blurred lines too, can you mention a little bit about, I know we're not going to go into coronavirus too much today, but I do think we've seen in the U.S. a couple of infectious diseases in the workplace blur those lines as well from a regulation and OSHA standpoint between H1N1 and then now COVID. Can you mention a little bit about that context as well?
Sure, and just I think setting the framework where a lot of physicians in my specialty would write medical opinions about work relatedness, and there's guidelines specifically from OSHA that speaks to contagious illness that is also found outside of the workplace is not considered work related. There was one specific exception for H1N1 flu, but now what we're seeing with COVID is that there is really this potential paradigm shift where employers are responsible for potential exposures of COVID in the workplace, and that may shift to other infectious diseases as well. As we spoke with the previous director of OSHA, there is this huge focus on control of infectious diseases in the workplace. And, this is not just in hospitals or in research facilities dealing with infectious diseases. This is applying potentially to any company. And so something that I would have never thought I would have seen in my career before, but it definitely applies. And maybe the last comment will be, again, these vulnerable populations where we see high-risk personnel that the CDC have identified with chronic medical conditions such as heart, lung, immunocompromised metabolic diseases are at much higher risk for severe disease. And that actually goes in addition to whether they're vaccines, regardless of their vaccine status. So I think we're really at this precipice of pushing towards a total worker health approach again.
Yeah, great points. And just a little bit about the broad context of employee experience and our labor market today, if you could just give us a little bit of information around that.
Sure. So ESG is this acronym called Environment, Social, and Corporate Governance. And I think Mark, our CEO, said kind of this came from the previous label was corporate responsibility. And really, this is the next iteration of corporate responsibility, to where companies are not only just looking for profitability, but they really are starting to look at how their company affects all of their communities that they work at, the social responsibilities, and even investors and shareholders are now starting to make some pressures to board of directors, and why companies are making decisions not necessarily just purely focused on profit. And I think specifically healthcare is probably should be a top priority there. There was this shift probably in the last 10 years of a patient-centered medical experience where you meet the patient where they're at. And I think we're starting to potentially adopt that on the employee health side, where we meet our clients where they're at. We support clients for many different programs and services, and it's really hard to determine based on a certain client's needs why they choose which program at that time. But I do think ESG will be a major driver for behaviors along healthcare. And I think as Dara and Dr. Dickerson were speaking earlier, the labor market has become more and more challenging, I think even before COVID, but now especially with COVID. And so, the workforce is absolutely the most critical component of most companies. And so the ability to recruit and retain top talent is critical. So if a company can develop a health insurance policy that provides amazing experience when it comes to medical and healthcare choices, will, I think, absolutely be a difference maker. And I think I'll speak to my personal experience later on in the topic, but when you're having a medical issue, it is very challenging to get care in a very timely fashion based on the current traditional model. And I know Dr. Dickerson is going to talk a little bit about kind of the cost side as well. And so potentially you're having a very poor experience at a very high healthcare cost. And so there's a huge potential impact if employers can make meaningful change to their health insurance management strategy.
Great points. Dr. Dickerson, anything before you jump into your section?
Yeah, I think healthcare consumerism, while I applaud, and I do think the millennials and beyond will be better, online consumers work with reviews, work with online platforms. But really, when people are under healthcare stress, they want a hand to hold. Even we as physicians, we want guidance. And we found that we had built an app for scheduling imaging, and patients scheduled themselves incorrectly a third of the time. And doctors leave the orders vague because they want a radiologist to hold their hand and make sure that the patient gets the right exam. So I think, I think one of the things that really makes a difference when I look at the solutions that are in place and that are emerging, kind of not post-pandemic, but within the pandemic, these healthcare solutions that are really changing employer health plans, it's the ones that are, that are people-centric. And, I think that the traditional system has lost sight of the patient himself and the patient experience. And I think a lot of the new things that are emerging, like direct primary care, direct imaging, direct radiology services, things like that, are really patient-centric. We're getting rid of the middlemen, and we're really focused on that great net promoter score, those great reviews on Google that reflect that we're doing our job and we're taking care of people.
Great points. Let's dig in a little bit about this journey of embracing change for employers. What does that look like? Sorry, is this for Dr. Cherry?
Right.
Or Dr. Dickerson, is this? Okay, sorry, Dr. Cherry, this is for you.
Oh, okay. So I was pausing for Dr. Dickerson, but when we look at how to make the workplace safer, I touched upon it earlier. And so NIOSH, which is the research wing of the CDC for basically employee health, coined the term total worker health. It's probably over 10 years now. I got to change my elevator pitch on total worker health. But I used to say it was 2, 3, 5 years old. But really, that's looking at kind of making a synergy between personal health and employee health, because really they dramatically overlap. But the biggest hurdle is who pays for it. And so obviously employee health insurance will not pay for it, and vice versa. But really workplace safety is absolutely critical with regard to safety sensitive work or physically demanding work. But, a lot of employees do not fall into either of those buckets, but you still have a huge amount of what I would call office workers, or maybe just lower physically demanding work, where they still succumb to potential injuries, slips, trips, and falls, which are usually the most common. And it can be from a mix of poorly controlled medical conditions, deconditioning, not engaging into fitness, wellness across the board with sleep, nutrition. And so there's really good studies and data, compelling data that can show the healthier the workforce is, the less injuries and more productive that workforce will be. And so you almost enter into what I call a win-win-win, where the employee is actually healthier and is able to contribute more effectively to the workplace, but they actually live a much higher quality life and for longer. And so, and they're less expensive overall into the healthcare system. So health insurance is actually one of the highest costs for companies, which I don't think many people understand. It may be in the top 3 cost to run a company. And so really there's this win-win-win where the employee wins, the company wins, but society wins overall, because you have a more productive member of the workforce, but also in personal satisfaction. And so I think a way to start looking at this through HR and the financial departments is having a discussion about how do we get the most value out of our healthcare spend. And I think I will probably save a lot of my comments for Dr. Dickerson, because she's obviously the expert with regards to maximizing your healthcare dollars, so to speak. But you can make meaningful changes in your healthcare program documents that allow for a more patient-centered or employee-centered experience, as well as more cost-effectiveness.
Okay,
and
let's
I would
dig
say
in.
a perfect
I'm sorry, go ahead, Dr.
example of
Dickerson.
that. I'm sorry. A perfect
No, go
example
ahead.
of that is Harris Rosen's story. Over 20 years ago, he dropped Blue Cross Blue Shield and his Rosen Hotels in Florida. He dropped Blue Cross Blue Shield and created his own health center and his own health plan for his employees. And with the money he saved, he has built up the schools in the area, built parks. He pays for the employees' kids to go to college. It's really, if you've never heard that story, it's a backstory to this school district case study. But it's a wonderful story. So anyone who hasn't seen that, it's worth hearing him tell the story. But this is a story that came our way in 2019. This school district, it's the poorest school district in Florida. It's the Kissimmee, Florida area, just south of Orlando. And the employees' wage increase for this school district was completely wiped out by the increase in their Cigna premium in 2019. And what that did was it got the teachers union to approach the school board and tell them that they felt like they were failing in their fiduciary duty to provide good health care for these employees. We look at that all the time with 401k spend to make sure that we're doing fiduciary duty, but there is an equal fiduciary duty to make sure that the spend on healthcare, especially when so much of it is being funded by the employees themselves, that fiduciary duty is being met. And so the school board did two things. What was happening was these teachers, the Cigna plan, they were spending 20% of their income on the premiums. Then they had a $4,000 deductible. Then they still had a 50% coinsurance up to a $6,000 maximum out of pocket as an individual. They couldn't afford care. And so they were going without care. And so they brought in, the Harris Rosen heard the story, read it in the newspaper, and volunteered his clinic that he uses for his employees as, he volunteered that model and that clinic to be the health center for the employees at zero out of pocket. And then they brought in green imaging at zero out of pocket for the employees. So they could get basic medical care at zero out of pocket, outside of that Cigna plan. And so if you look over to the left, our original pricing in that area was, $525 for an MRI. But this was 10,000 lives covered by this health plan. Plus, the Rosen Health Center loved the customer service they were getting for us, and they joined Green Imaging. And so now we have 16,000 lives, in a tightly aggregated geographic area. And so we were able to get the cost of the imaging down and negotiate that down about 20%. And so in 2020, despite the pandemic, we saved the school district and the employees $1.5 million, and we're on track for $2.5 million this year. And they are, it's been a paradigm shift. Now the school board goes in and looks and makes sure that they're getting, always before people have worried, if it's zero out of pocket, aren't people just going to go get imaging done? Well, no, we're not going to go lie in a cold tube and listen to a banging and take a day off work to go get an MRI, unless there's a reason for it. And so they're making sure their audits are actually to make sure the employees are getting the care they need, which is really cool. And it is a paradigm shift, and it's the subscription-based primary care where, the employer is paying a flat fee for these people to get zero out of pocket the health care they need at the Rosen Center. And that's just a better way to provide health care.
Wonderful. Let's dig into Scott's experience with this as well.
So I'm incredibly thankful and about my experience with green imaging. I kind of have two experiences. One, I want to kind of it's my own personal experience where I was having severe abdominal pain and really could not get into my primary care provider for, assessment and referral. I actually went to an urgent care center that I thought would, kind of as a last resort. And even there, I was going to have to wait, several hours. And so even though I was really in intractable pain, I literally just went home and crawled into bed with just very, very uncomfortable. And so what was interesting to me was, although I'm in healthcare and I am insured, I really was at a loss for getting the kind of appropriate guidance, even was as a kind of an insider into medicine. And, fortunately, I had met Dr. Dickerson a few months prior. And so I did reach out to her to see if I could, get some imaging for my abdomen. And I really felt the most care I had ever felt, maybe outside of the military healthcare system, to where not only did I have quick and kind of concierge type of experience, but her whole team made sure that, I was taken care of and then quickly had the results. And so, in many ways, I think those who aren't in healthcare are going to feel more lost in the system. And we do hear about overutilization of the emergency room. I probably should have gone to the emergency room based on kind of how things unfolded later on. But, me being aware of kind of overutilization or abuse of the emergency rooms for kind of the inappropriate reasons, that was kind of in the back of my mind. But I think what really resonated with me was, even though I was well insured, I was kind of not able to get appropriate access to care in a timely fashion. And so having relationships with networks and providers that are kind of from a more transparent and direct relationship is absolutely critical. And I think that that's part of the problem. If people feel like they do not have a partner in their healthcare, then they're going to just go to the ER, and obviously they do share some of the burden, but the employer also will actually experience a lot of that cost as well, especially if it's not needed appropriately. And so, my personal experience, although it's an anecdote, absolutely, I think, is the common experience for many people when they're in an acute medical issue. And then I also think about it from a chronic medical condition. And I think that's where direct primary care really can make a big difference. We haven't spoken necessarily about that here, but I think a lot of primary care doctors in the traditional health insurance model have to see a certain amount of patients per hour for various reasons. And so it's hard to build a rapport with that primary care provider in a very short time period. And so I think really the direct engagement with healthcare providers, whether it being primary care, imaging, and then also I think the other big spend is the pharmacy benefit. But there really needs to be a paradigm shift in healthcare provisions to where you have more of a direct model. Just like if you were going to buy anything else in your life, you would know the cost, see the value, and decide to purchase it or not. So, Dr. Dickerson, I don't know if I didn't have really my head screwed on very well back then, but I don't know if this is commonplace for you and your team and your network, or if I just happen to remember our relationship and kind of engage you on a kind of emergent basis. So I don't know. I never got to ask you if that's more common or not. So.
Now, we really consider ourselves providing direct radiology services. We think the radiologist should be around. My background is with multi-specialty groups, and the multi-specialty groups I worked with paid more to have in-house radiologists that they could come down and look at images with. They saw that much value in being able to discuss the cases with, and they would even bring the patients into the reading room and say, he hurts right here. What do you see? And that's better care. And so we are very actively involved in our practice. When orders come across in our referral management system, we're actually reviewing the orders, making sure the patient's getting the appropriate exam. If it's ordered with and without contrast and it only needs to be without contrast, we're removing that contrast and that extra radiation dose and that extra expense. And if an ultrasound could do the same job or do it better, we go back to the referring physician and discuss that. We're right there on the platform with a group chat where direct primary care doctors, near-site clinics, on-site clinics can actually chat with us and say, what's the most appropriate exam to order here? Or what did this mean in this report? We can ask patients questions. It actually has a secure HIPAA-compliant messaging system that comes across like a text to the patient. And I can say, hey, when you had that contrast reaction 5 years ago, what happened? Did you just have a little throat swelling, or did you actually, have hives? What happened there? And so it really it changes the way radiology services are provided. And we really found that, when that app failed for patients scheduling themselves, that's when we realized we had to have a really robust concierge service. So that team effort that you felt about getting everything, not only getting you scheduled, but getting the report across to you, that's very commonplace. And if you look at our, and I'm bragging, but our Net Promoter Score is 90.2, which is world class, despite the fact we're frequently relocating the way, changing the way people acquire imaging. And our Google reviews are 4.9, and our concierge are almost always called out by name in those reviews. So I think that reflects the difference in the way we practice.
And I think that makes a huge difference on outcomes. The psychological reassurance that you're not just a number, or you're not sure if everything is in, or when am I going to get the result. Reassurance and psychological, feeling safe, or at least that you matter versus just a business transaction makes, I think, a huge difference in medicine. And I think that's a symptom of maybe the kind of the current model where there's a lot of third party or middlemen in that transaction. And so, I can see people getting frustrated, whether it's kind of routine chronic care or just getting a physical. I think a lot of our discussions with COVID are, hey, if you haven't gotten a physical in the last year or 5 years, now's a great time, because it would be really helpful to know if you have any of these medical conditions that make you more predisposed to, COVID, obviously for this pandemic, but it matters for your quality of life and your health span and lifespan. So, I could absolutely see why your network continues to flourish and your business model does as well. So I'm a customer and a huge fan. So thank you very much.
Great promotional statements, Dr. Terry.
You can't pay for that.
You can't. We didn't. I promise. So when you think about, both of you just said the words concierge medicine. I think, just to go back to your case study briefly, Dr. Dickerson, if you could I think people hear concierge and they think expensive, or they think elite, or they think I can't do this or access this. And we'll get into some considerations for employers in just a moment. But can you just address that directly a little bit?
Yeah, there are a couple of, direct primary care likes to differentiate itself from traditional concierge medicine. Concierge medicine frequently is something that's layered on top of an insurance plan, and somebody pays up to have better access to their physician. Their physician takes a limited panel and may include some screening exams and some extra services in there. Direct primary care is different in that the whole idea is not just looking at a patient's physical health. They're getting paid a monthly fee. It's enough that if they have a certain size panel, they make a decent living without having to see 22 patients a day. They can take 24/7 care of these patients. They take calls at night. They do everything they can to not only manage the patient's physical well-being, but also their emotional well-being and also their pocketbook. And they find resources, whether a patient's insured, whether a patient's on a health sharing ministry, whether a patient's uninsured, they find ways to decrease the out-of-pocket spend. And, that is super important, because really, if we look at it, and there are different numbers tossed out there, but about 90% of care can be handled at the primary care level. If that happens and people aren't seen in the ER, and what happens a lot of times with the DPC doctors, if they have to send somebody to the ER, they're also going to make sure their imaging exam doesn't have to be repeated, that it goes across, their labs go across, so that we're not providing redundant care. And they monitor, they want feedback from that doctor, the ER doctor, about what's going on. They stay engaged to make sure that that patient is well taken care of, even when it's in kind of the more traditional space. And so what we're finding in health plans is it's anywhere the estimated savings so it's hard for employers to see this, because it's something they're paying for on top of what they're already spending on healthcare, or what they perceive they're already spending in the, for the PEPM, which is the per employee per month that they're paying to have a network for their employee health plan. But what they're doing is investing, because the savings down the line in the health plan are 20 to 50%. And so it depends on, how incentivized employees are to use the DPC. A lot of times they'll use it kind of as a telehealth experience, love it, and then continue to get all their care there. We love that. We like that model as well for the zero out-of-pocket imaging. They come for their mammogram in a low-stress time and, have a great experience, and then they're much more likely to use us when they're, having abdominal pain and in healthcare stress. And so I really believe in the subscription-based primary care, whether that's an on-site clinic, whether it's a near-site clinic, whether a lot of this is happening by telehealth with larger employers who have a wider geographic range. Some of this does have, even if it's with a DPC, some of it has to be farmed out to other DPCs or has to be by telehealth. And a lot of DPC work does happen by telehealth, but there are really great options out there that not only, and it also takes away this idea of a health plan being a year-long thing. Everybody used to think of, we don't want them to get to their deductible or we're going to have to spend that. And, it puts healthcare into I'm investing in the future of my workforce. And I'll tell you what, right now, during COVID, during the pandemic, it is a much better thing to have your people have resources where they can go affordably get care 24/7.
That's a great point. And to Dr. Cherry's point, not plug up the ER with things. Let's talk about considerations on rolling a program like this out. So Dr. Dickerson, if you can kick us off here.
Sure. I think one of the things that happens is I used to hear brokers say this all the time, the people who sell insurance, that every health plan is different, and every health plan is different. There's a different mix of employees, of wage levels. There are white collar practices like law firms, and there are more blue collar industrial practices or companies. Health plans differ dramatically. People's healthcare needs differ dramatically. If you've got truck drivers and people doing heavy lifting, their MSK needs are much different than people who are sitting at a desk all day. And so I think, the first thing to look at when assessing a health plan is you got to look at that. You can't just hang a Blue Cross Blue Shield plan out there and say, this is going to take great care of my employees. I think, there are, again, location and accessibility constraints. We found that we thought we could be HEB and just be in Texas and provide great care. And we couldn't, because larger employers have lives all over. Their kids, even if everybody lives in Texas, somebody's got kids in Florida. And so location and accessibility constraints, a lot of those are going away with telehealth and with solutions like ours that are national but allow an aggregated way to acquire the services. Best practices, the direct care adoption, these are all great solutions, and there are tons of solutions out there. Doctors have been tremendously innovative during the shutdown and the pandemic and have started all kinds of great startups out there. The thing I'm concerned about is not the availability of great medical services. It's how do we tie them together? How are we going to integrate those? And then how do you educate employees and communicate to them that these are the benefits they have? That's a big challenge. And they really only want to hear it when they're sick, is what I've learned. They don't really want to sit through a 30-minute video on December 20th and hear about next year's benefits. What they do want is an easy way to know and get those accomplished. And so, Scott, I'll let you speak to those factors.
I think what resonates with me, too, is from just purely the employee health side, there are workplace exposures that directly need ongoing medical surveillance exams, even beyond employment. What comes to mind are a lot of pneumoconiosis, which are essentially dust exposures. Some of the big ones are silica and asbestosis. And so what's interesting is maybe we can discuss it, further, offline, but having that approach where, employees are concerned about their lung health, or do they have risk of kind of developing these work-related illnesses down the road, having that ability to, schedule themselves is usually quite, makes a difference. And so, I think that, there's really a host of opportunities that can, again, bridge the healthcare needs that span across employee health and, personal health. And so, seeing how, direct radiology can be so much more efficient from, again, the employee's experience, but also the cost benefit. Something I've learned is that, again, whether it's a for-profit business or if it's an organization that is given a budget, there's limited resource there. And so if you can make a difference from a cost savings perspective, that frees up that resource for other things in an organization, or it creates more profit for a for-profit organization. And so it's really, again, kind of that win-win-win perspective that I don't want to say it's low-hanging fruit, because I know what you're doing is not easy, but there does seem to be that value proposition there if an organization is willing to look at making those changes.
Great points. We've had a lot of questions come in, so let's get to that. We have about 14 minutes left, so I don't want to lose time for questions. Mm-hmm. Let's jump into the first one. Paula asked, why and how can there be such a significant difference in price from one facility to another for imaging? And I know you've talked a lot about this, but any other specific feedback about why prices are so different?
Yeah, there are multiple factors. Number one, hospitals and insurance companies negotiate on their own. I've had a number of people who used to work for insurance companies, and they negotiate, kind of behind closed doors for their contracted rates. And the big hospitals have a lot of leverage. The insurance plans want to have Texas Children's, they want to have MD Anderson, they want to have Methodist in their plans, and so there's a lot of leverage that those hospital systems have. So, Memorial Hermann, you're going to pay about $1,300 for a non-contrast MRI. Methodist about $1,600. That's a big ticket. What's also happening in this space is that there's a lot, especially, and this is a pandemic effect, because there were shutdowns. Both radiologists were reading exams at about 50% capacity for a large part of 2020. Imaging centers were performing exams at about 50%, even less than that for the 3-month shutdown. And so there are a lot of financial strain in those spaces, and there's a lot of private equity money out there that's been gobbling up the radiology groups and the independent imaging centers. And what they do is they pull all those old contracts, that maybe it's in North Carolina, there's a 1,400 radiologist super group. It's all the radiologists, I think, in North Carolina, and probably 40 radiology groups pulled together in this private equity-backed group. And they review all 40 contracts for United Healthcare or Cigna or whoever it is, and they bill under the oldest, best contract. And so what we're seeing in the space is we saw prior to the pandemic, the total percentage of the imaging spend that was the professional fee, what the radiologist gets paid, was 22%. We have a set of Blue Cross Blue Shield claims data that was the first half of 2021, and it was 45% of the imaging spend. And believe me, the facility fees didn't go down. So this is just the increasing cost. And we're seeing that in the outpatient imaging space as well. It used to be kind of the safe harbor, the safe place to go get less expensive place. But these chains of imaging centers are, again, aggregating, as they acquire these groups, they're looking for the best old contracts and billing under those. And so, and I will say, on the other hand, Medicare has cut imaging reimbursement 60% since 2007, despite the fact our costs are going up, especially this year. And so, it's a really broken, Medicare's a broken reference, and then the system itself, it's not free market. There are a lot of market forces there that are not in the favor of patients and employees and employers.
Makes a lot of sense. Hunter asked, are imaging services available after hours and on the weekends?
One of the really cool things is we talked, when we talk about the win-win-win-win, people say, why would these imaging centers want to work with you? And I can tell you the answer to that because I've owned imaging centers. I answer their pain points. We give them a clean order. We make sure that if the patient doesn't have their order and the doctor really doesn't want to give it to the patient because they want them to stay in the hospital system, we go and get that order. We pay them promptly and we pay them a fair price. And so, they're very happy to see our patients. We want to be the best referral source in areas. And where that's happened, especially in Florida and here in Houston, where we have large numbers of lives, we're the best referral source. And so now Orlando Diagnostic Centers is open on Saturday and Sunday for the school district and Rosen employees. And so we do create, I can't say across the board that we have after hours and weekends. We're really compiling a database. We have 1,400 imaging centers, and it's hard to keep up with who has evening and weekend hours. But we do try to seek those out for people, and we want to figure out some ways to work with hospital systems such that a DPC doctor can generate a voucher for a patient and send them over to a center that they know we work with and get them imaged nights and weekends to try to save on that imaging cost.
Wonderful. Kate asked, would a third-party imaging facility accept insurance or direct pay only? So do they do both, or is it typically one or the other?
The centers that we work with, almost always, there are a few that are just self-pay centers, but most of them do accept traditional insurance, and we can usually point somebody that direction. But if you are not planning on, you don't think you're going to meet your deductible this year, you are actually a self-pay patient. And you need to compare the contracted rate with the insurance at that company compared to a cash rate, where at whatever reputable center you can get it. Because there's no reason to, if you're not going to meet that deductible, healthy, you just, have a strain and want to make sure you don't, you're running a marathon, you want to make sure you don't have a stress fracture. Get that MRI, self-pay. Don't go through the auth process and the, all the headaches that go along with using your insurance. But what employees don't realize a lot of times is that not always is Blue Cross Blue Shield on their health plan. A lot of self-funded healthcare plans may not have a network these days. They may be reference-based pricing, or they may have us written into the plan. And more that's the case when they have an independent TPA, when they're not with one of the traditional TPAs. We're actually written into the plan, and we are the option.
Interesting. Good information. Let's see. We already answered that one. Bonnie, what type of feedback have you gotten from employer partners?
We get great feedback, and I think it's probably on our website, but the risk manager at School District of Osceola County has a great quote on there. Not only have they had great service, but they've saved 60% on their imaging cost, and actually 79% on their CT scan cost. And actually on that school district Facebook page, there are a lot of patients talking about the benefit, employees, and that's really cool to see as well. But, I think you will see that in our Google reviews as well. People talk about, and they're grateful for their employers for providing the service as well.
Wonderful. I think that's it. Let's go ahead and any last thoughts from you to start with, Dr. Cherry?
Let me see if I have anything additional. Can we go to Dr. Dickerson maybe? And I had something, but it just escaped my mind.
Sure.
Absolutely. Dr. Dickerson.
I think imaging is a great start. There are so many things that can happen now. There are musculoskeletal programs, near-site clinics, on-site clinics, so many different changes employers can make in their health plan that make such a difference. But imaging is one of the really easy, we can be bolted on any time of year alongside a traditional healthcare plan, and you can start to see the savings. And when you start to see that kind of savings and the better service, the better patients feel about their health plan, employees feel about their health plan, the more, and what we see is, and I'll tell you the coolest thing, Axiom, started out with us with a low copay, and ultimately when the pandemic hit, actually dropped that to zero out of pocket for their employees. I tell that story all the time. I think that's just awesome. So I think you start seeing what better healthcare can do for your workforce, and it's a great starting point.
Great.
You know, I think what I wanted to reinforce was, again, having very employee-centric, effective healthcare really can make a difference with employee morale. We do realize mental health can always be challenging for populations now and even before the pandemic. And so I actually do think engaging into the traditional healthcare system can actually add to some of those challenges. And so this can be a significant way to lower the burden on your employees by considering some of these changes that, again, make things less expensive, more accessible, and just a better overall experience.
Yeah, great points. And I do think that, to your own case study, the great point out of that is that even those that are in medicine and have every resource available or understand systems struggle to get the right care at the right time. And I do think that's something that Axiom has seen on the workplace health side and on the personal health side, that getting access and having to navigate a really complicated system isn't easy for anybody, even those that are in it. So I appreciate those that are trying to make it easier and more cost effective for the entire population here. So we'll continue to keep trying to drive change and see what we can do there. I really appreciate you both joining us today. Thank you, Dr. Dickerson. Thank you, Dr. Cherry. Great discussion. And we'll be coming back in 2 weeks with another webinar. But like everybody knows, as things are unfolding with the OSHA COVID emergency temporary standard, with Omicron and variants of concern, Axiom will continue to put out webinars and content as we learn more. We did one yesterday and it was really great, and we'll continue to put more information out as we get it, including this free guide to the ETS. We also have a bunch of other information in our resources, and we really appreciate everybody attending. Thank you all. See you in a couple weeks.